Welcome to the On Your Mind podcast, where we are changing the mental health narrative, bringing hope and solutions. Here's your host, Timothy J. Hayes, psychologist.
Steve Miccio is Chief Executive Officer of People USA. Inspired and driven by his personal lived experience, Steve has spent over 2 decades creating, providing, and promoting innovative crisis response services and systems-level improvements, both across the United States and internationally. These improvements raise the bar on customer service, person-centered communication, trauma-informed care, empathy, and positive expectations for people's recovery and wellness outcomes. Steve's unique models and approaches significantly reduce hospital utilization, incarceration rates, and overall healthcare spending. Steve, thanks so much for being here.
Thanks for having me.
It's a delight to finally meet you face to face. I've heard a lot about you. I wonder if you could start us off by telling us how you got into the work you do and what drives your passion for it.
Yeah, sure. I'd love to talk about that. What got me into the work was my lived experience of what happened to me and how I ended up in the mental health world. Prior to being diagnosed with bipolar disorder, I had been struggling through life with, ups and downs and never really could figure out, what was wrong or what was happening or anything. And still able to, function well, had good jobs and all that good stuff. But it was challenging. I'd go into these very depressed states and then I'd go into these very energetic states. So it was a challenge. And in the mid 90s, it all kind of came to a head for me where I was very successful in my work, but then at the same time, I was just dealing with this very energetic existence and doing things that were just made no sense. And my thought processes didn't make sense. And it was strange because inside I could feel and question myself and say, what are you doing? But I couldn't change the behavior. And it was very challenging for me. And so I ended up going into a psychiatric emergency room and hospital and being diagnosed with bipolar disorder officially. It was the beginning of my experience of how ridiculous I thought the mental health system was. Because I ended up in this hospital and the first thing they did was give me this cup full of medication, different medications that I didn't really question or understand. I was just so scared at that point. I took it and stayed in the hospital for, 7 or 9 days, whatever it was. And never heard the word hope, never heard the word recovery, never heard anything that was positive coming out of it. All I heard was what was wrong with me and my diagnosis and that I was going to live with this the rest of my life. And it kind of, I always tell people I went in as Steve Miccio, I came out a mental patient, and I did. My self-esteem was gone. I had no hope at that point. I thought, oh boy, this is it, and I'm going to end up, having to go to these services the rest of my life, taking this medication the rest of my life. And I didn't know what the future held for me. So I just came out of it not knowing anything. So after I'd come out, I was working in the developmental disability world, and I was employing people and creating innovative work for people that were functionally, physically capable of doing things, but mentally they were nonverbal. They had all different diagnoses in the DD world. And I had been training them on how to run a greenhouse and how to cut lawns and how to do things that were probably not the norm for people that you would see with the level of developmental disabilities that I had. So I was actually successful at it. And we were on our way to really building this affirmative business with people with disabilities. And they came in one day and after my hospitalization and said, you have one of two. This was just after I was promoted. You have one of two choices. You can take a job that is more of a direct care in one of our houses, or you can leave. And I just, what happened? I mean, we've been doing this job and I've been doing so well at it. I couldn't prove the discrimination, but it was right there in front of me. And so I did leave. I didn't know where I was going to go. And I did pick up another job, and it wasn't my passion as much. It was still in developmental disability world, but it wasn't the passion that I wanted. And I was just more driven now towards mental health and understanding it and understanding the system of care. Because there was, in New York State, there's different divisions of, departments. There's the Office of Mental Health. There was the Office of People with Disabilities, Developmental Disabilities, and then there's the Office of Addiction Services. And I had never interacted with the Office of Mental Health or their services. And now I was in their services and going to see a psychiatrist, seeing a therapist, and still trying to figure myself out and what was happening for me. But then I got this additional job after I started to recover. And my recovery really came from a book that was called You're Not Alone. And it was written by people with depression and mental health issues. And then I went to my first peer support group. And this was a group of people diagnosed with bipolar disorder that I sat in. And they all were telling their stories. And I heard my story and their stories. And there became my self-determination. There became, that's where I got my hope. That's where I started to feel empowered to do something for myself and think of myself differently. And so that's how it started for me. And then I got this job at a hospital when I was in my recovery, in an emergency room, screening people with psychiatric crises. And I was like, this is great. I'm going to love this job because I can treat people the way they should be treated, not the way I was treated at the hospital. And that's what I did. I knew where to get them the best food. I would go and steal it from the kitchen, and I would make sure that they're hydrated, and I would make sure that they're comfortable in the small screening area that we had. And I loved that job. I said, this is how I think it should run, and so that was my experience there. And then I was introduced to this peer advocacy organization called People Inc. And they were looking for an executive director. I applied for it. And after 5 interviews, I got the job. And my thought was, oh, now I'm in advocacy. I can advocate for the hospital that I was hospitalized in and make it better. But what I found out quickly was that they wanted nothing to do with me, and they wanted nothing to do with my organization. So my advocacy mentality had to shift, and it had to become, a little more aggressive in what I was doing. But now I was beginning to understand the world of people with lived experience and the world of psychiatric, care and the Office of Mental Health Services that were out there. And I was fortunate because I got to be on both sides. First, I was the person that locked in the unit. Now I was the person with the keys when I worked in the hospital. And I started to understand both sides. That's what got me to where I am today, which is running a peer-run organization, doing a multitude of, I think, really great services in our communities.
So tell me a little bit more about what is this organization and what's the range of things you do?
So this organization began as an advocacy organization. It was very small when I started it. I think we had maybe 9 staff altogether, serving 2 counties, and we had 2 drop-in centers, which were really just safe havens for people with mental health issues to come and hang out and have coffee and meet us and talk and, kind of peer support. A lot of peer support was going on there. And then the advocacy component was helping people transition from inpatient psychiatric centers into community and advocating on the services in the community to ensure that the people were getting the services that they deserved when they were released from the hospital and living independently. So the advocacy, I was really throwing rocks at the system. I was out there going to these provider meetings and criticizing the system of care, talking about the marginalization of people with mental health issues, and just wasn't happy with how people were being treated because we were getting those stories every day from different communities that we were serving. And so I did a lot of advocacy, and I did raise a lot of attention around hospital crises, emergency rooms, We did a whole expose on one of the hospitals here, the hospital that I was actually hospitalized in. And we picketed and we demonstrated. And we, in one hospital, the administration or the board of the hospital recognized that they were being criticized for the quality of care in their mental health services. And the board decided to terminate the administration of the hospital, and then came to me and said, can you put advocates in our emergency room to help us make it a better place for people to come to? And I was like, absolutely. And I was fortunate because I had the experience of working in the emergency room. So I built this whole kind of training around putting peers into the emergency room on how to greet people, how to be more trauma informed and practice safety, when people came in, and making them feel safe when they came in, and telling them, being transparent and telling them what they were about to go through. So I started moving the organization into a service organization, peer-run service organization. And that was my first new service that I kind of introduced into our community. The next one was the peer respite. And at the time when I was designing it, I designed it with the help of Sherry Mead, who had a respite out in New Hampshire. And her and I were starting to put together the ideas of how to run the respite and things. And, we had some differences and some similarities. And so it helped me to help, really design what I wanted to create. And the respite was simply more of a bed and breakfast environment for people to come to in crisis and have 24-hour peer support. And they could stay 5 to 7 days, 1 to 7 days, really, at the respite, and really get into the crisis of what brought them to the house, thinking of the alternatives and the decisions that someone can make to avoid crisis in the future, kind of building a safety plan for themselves and building a wellness plan for themselves. And that was the first house that really was funded by the State Office of Mental Health to operate in New York State. And I really thought
let me get this clear.
Sure.
Is that something people would do before they would go to the hospital in crisis?
They could do it before, but they could do it instead of going to the hospital in crisis.
Right. That's what I mean. So instead of getting referred from the hospital, you're talking about creating an awareness within the community so that if somebody is identified as approaching a crisis point, they could go to this peer respite.
Exactly. See, I used to call it a hospital diversion house. And that was, people told me that was kind of rough language. When you call something a crisis or hospital diversion house, the community doesn't take that as well as hearing a respite house, So, but the whole idea was, a lot of people don't need that level of medical intervention going to an emergency room and going to an inpatient unit. They need someone to listen to them. They need compassionate care. They need someone with lived experience to share their stories so that they can feel that they're not alone, and they can understand that recovery is possible and that hope is important in someone's recovery. And so we do that in the houses by lending the vision of hope, by expecting recovery. The mantra in our organization is that hope greets you at the door and recovery is the expectation. And we've lived by that, over the 20 years that I've been here, and we truly believe it. And so that's what the house was designed to do, was help break the crisis by, many people go through home to crisis to hospital, home to crisis to hospital. And my goal was to break that cycle. And we did. And we're 95% successful in doing that with the people we served over the 21 years that we've been operating.
So I'm very curious about, how do people find out about it? How do you get the awareness in the community out there so that instead of, being rushed off to an emergency room, people find your respite care?
Yeah, that was a learning process for me. I expected when I opened that people would just come, they'd flock in. And there were two things that were kind of the challenges for us was, nobody did know about us. And the people that did were the people that were still connected to the psychiatric hospital system or just fresh into the community. We had kind of not a captured audience, but we had a lot of people that were freshly discharged from hospitals, and they were the ones that were starting to come to the house. The other was the provider community didn't understand it and didn't trust it, of course, knowing that people with lived experience were going to run a crisis house. That was a big shift for them to understand. And so I knew I had to build integrity and success into this house. And what I went into it very optimistic, thinking this is going to work. This is going to be great. And what I was hearing from the community is, what if someone kills themselves at the house? What if somebody cuts themselves at the house, or if they overdose, or if they whatever? And my response was always, what if they love the house? What if they love the way they're treated? What if they realize that there's a different way of treating people in crisis, and there's a better way, and there's a better way of communicating and engaging and developing a relationship with someone? That was my whole focus. It wasn't about the danger of what it could have been. It was about the optimism of what it was. And that, I think, was hard for people to grasp as well. And I can tell you, in the 21 years that we've been running this, we've never had any kind of situation like that, where someone has died at the house or overdosed, or the violence. There's been no violence at these houses or anything. This is a voluntary service. And when people were getting agitated, or if they become agitated at the house, the staff simply say, well, you don't have to stay here. You can go. And then they think differently. Like, well, no, this place is too nice. I don't want to leave. Let's have a conversation. Let's talk about my anger. Let's talk about my issues. And that's what happens. And so, it is a very successful house that I've helped open probably 40 houses across the country and in the Netherlands now, that are operating under the same principles of what we created. And it's growing. More and more states and more communities are learning about it and wanting it. And now it's to the point where I also realized I had to make a relationship, or build relationships, with the provider community and with the police in our communities, so that they understood what the house was about and they could use it to bring people to. And that's what we did. And we have this great relationship now, where with all the law enforcement departments and with the community providers, where they understand it. It took about 5 years for people to understand exactly what this was. Now they understand it, much faster, because we also market it differently too. And we've learned how to market and got into the marketing of, coming to the respite. So it was a learning experience to get people to really embrace it. And now it's highly embraced in all the communities that we serve. We have 4 houses right now that we run. But again, I stay very close in contact with the other respites that I've helped to open. And I try to keep things, true to the fidelity of our model that we created. And for the most part, people are doing that, which is really nice to see.
Wonderful. Well, as a provider myself, I'm curious about what the form or the model was that worked best for you in communicating and establishing that rapport with providers.
Yeah, it was about being at the table and being a voice at the table, not just sitting at the table. I'm a pretty blunt person, and I would go to these provider meetings, and people would, talk about how great we all get along and how great we work together. And I would sit there and say, no, we're not working together. We're serving people that are under your services, that are having difficulty getting entitlements, that are having difficulty getting in their appointments, that are being discharged for missing appointments, when it really should be the other way. Why aren't you making it to the appointments? And why aren't we providing you some kind of assistance in getting to those appointments? And so I would be very honest at these meetings, and I raised the bar.
And furthermore, how can we make the appointments something these people want to go to?
That's
yeah. So we don't have to. How do we make the appointment something that we don't have to drag people kicking and screaming to get them to go? Yes,
that is so true. And
which is essentially what you did with the respite houses.
Yes.
You've taken that model of compassionate care and made this something that not only do people want to go there, but when difficulties happen there, they want to work to stay. It's that nice.
Yes, absolutely. And I even have now a crisis stabilization center that we run, and it's pure run. And it's probably the only one in the country that's peer-run crisis stabilization. But we do have clinicians, and we do have case managers, and we do have some chronically normal traditional people working in it as well. But it is exclusively peer focused and trauma informed the way we designed it, which is also very successful, and people want to come to that. I keep telling people we want to be the Disney World of mental health, not for the fun of the crisis, but for the actual care that people are going to receive when they come into our services. I was fortunate enough to work in Brooklyn for a while. A judge had asked me to work in Kings County Hospital because a woman, Esmond Green, had passed away in their psychiatric emergency room, in the waiting room, and she was dead for an hour before anyone came over and checked, and it was unfortunate. The fortunate piece that I say that I had was they asked me to bring peers into the hospital to help engage people that were coming into the emergency room and help engage people that were in the mental health units. So I developed a training on how to do that and what that looked like. And one day I was standing in one of the mental health units, and one of our peers came walking in for their shift, and all the patients in the hospital, not all of them, but many of them, saw the peer come in, and they all surrounded that peer and wanted to talk to that peer and tell them about their day. And I was standing in the nursing station, and there were social workers and nurses and other staff standing there. And one of them said, look at this, when I walk into the unit, nobody comes and greets me like that. And I said, because you suck at it. And what I meant was, you don't engage. You're not engaging in a very compassionate way with the people you serve. So I did a training for the traditional staff as well, which really shifted the paradigm of that hospital to a better quality of care from the emergency room into the mental health units. And it took about 18 months to do that.
Yeah, it puts me in mind of talking to, I believe her name is Kate Duffy, and she, do you know the name?
I know the name. Yeah.
Okay. And she tells a story about how she couldn't get people to agree to talk with her. And she was this social worker. And finally she settled on, well, ask them, instead of they want to talk to a social worker, or ask them if they would be willing to talk to another addict. And
yeah.
The yeses went through the roof, over 90%. And so she met them as a peer. She could bring all of her other expertise after she connected with them as a person.
Yeah. It's incredible. The lived experience is, the secret sauce in substance use care and mental health care. We know it, we live it, we experience it. So it's a powerful tool that complements tradition.
Right. But then it's first I have to connect with the person as a person.
Yeah.
Right. I mean, one of the things I was going to say when you're standing there in the nurses station with these social workers and nurses is, nobody comes to greet you because you don't connect with them as a person. You look at them as a compilation of symptoms and a label.
Exactly.
And notes that need to be made instead of connecting as a person.
Yes, absolutely. And we've changed the whole engagement process at the stabilization center to, you don't come in and just start doing paperwork. You come in and we get you comfortable, and we say, what brought you here and how can we help you? And here's what we can offer you, and tell them, we're very transparent about what they should expect from us and what we expect from them as a guest. And we call them guests when they come to our houses and our stabilization center. And then we tell them we do have to do some documentation. And here's why we have to do it. One is because we got to get paid for this. But the other is we want to get to know you better. So we use a motivational interview process when we go through the documentation to get the story. And within that story are the notes that we would have to actually write. And so the staff are trained on how to do that. And it's a much calmer and I keep saying trauma informed, but it's just a more respectable way of working with people and understanding, what they've been through and what happened to them and how we can help them. And it works well.
Well, I feel like I kind of interrupted you when you were on a flow of talking about all of the things that you do. So you want to come back to that and
Sure. So the respite was, like I said, the one big thing I think we really created that was a paradigm shift. But as time went on, I realized infusing my staff into not only the emergency room, but into other services would also make sense. So I started working with the provider community and the county governments that we work with. We serve 9 counties, so we're in a bunch of counties doing this stuff. And I started asking them if we could put our folks in their services. So they're in the partial hospitalization program, they're in the clinic, they're on the streets, they're doing the outreach on the streets as well, and greeting people. And so that began expanding. And then we got more into supported housing. And we have over 200 units in different communities where people live in our housing services, and we pay 2/3 of their rent. They pay 1/3, and we help them to get work, to how to live independently and how to be successful independently. We use a housing first model, which means you're not going to lose the roof over your head ever. Even if they're asked to move because of some issues with the landlords or whatever, we always find them a place to live. And so they don't lose the housing, which focuses them more on their own wellness and the recovery when they don't have to worry about losing the roof over their head. So that's also been very successful. We have a mobile forensic peer-driven team down in Westchester, New York, Westchester County, New York, that works with police organizations and helps engage people when the police are working with someone to say there's an alternative to the incarceration here. There's the alternative to arrest. And we can help you with that if you agree to go to services, and we'll get you to those services within the 24 hours that we need to, and then we'll follow up with you. And we've been, again, very successful in also working with the court system and getting to know the judges and saying there's another option. Instead of putting this person in jail, treatment would be a better outcome for this individual, and they're willing to do it. And so we work with the judges and the court systems on that alternative as well. And again, has been successful when the judges embrace that and they use it, and they have been more and more, which has been great. All the other services we have are mostly staff mobility, getting out there and meeting people and providing support groups and providing education and wellness groups, resource groups for different, folks in different communities, which ties everything together. And then we have 24-hour phone support for everybody that's within our services. And if they're in trouble, they can call us anytime, and they're going to get another peer on the other end that's going to help walk them through whatever it is they need, in their support.
And how do you fund all of that?
We're pretty fortunate that the State Office of Mental Health has funded most of it over the years. But some counties that didn't have the funding that was coming through the state went to their own legislation, and the legislature in the county has funded the services because they see the value in it. And we show a lot of return on investment in the work we do. I didn't do this to save money, but when we sat back and looked at what the effect was of not using Medicaid or not using the level of intensive acute service delivery, we found that we were saving millions in the communities. The stabilization center itself is able to save $12 million a year on cost avoidance. The Rose houses, the respite houses that we have, we call them Rose houses, are able to save between $6 and $10 million a year in cost avoidance. So it makes a big impact, and it's getting more and more notice now in the political communities. We have more and more representatives and senators and folks coming through our services and looking to to replicate those models that we've created. And we're now working with the state of New York on the licensing and replication of these services. And they're now funding these services through their own dollars, which is allowing us for expansion as well.
Wonderful.
Yeah.
Well, so feel free to push this question off.
Sure.
But as I sit here and I listen to you, you started with your own story.
Yeah.
Part of my mind is saying, well, so how did you make a transition from that diagnosis and that disrupted functioning to this higher functioning? What forces and factors, whether it's medication, therapy, or other things, have you found most useful in getting your life back in balance?
Well, I found for a while certain medications that helped me. But as time went on, they were hurting other parts of my body. My kidney functions were starting to, get a little screwy, and my liver functions were not, the best. And so I wanted to find a way of being medication free. And, I would have these arguments and disagreements with my psychiatrist. But I started doing it. And what I found was my passion for what I was doing, that structure drove my behavior. And so becoming a strong advocate, becoming a visionary, becoming somebody that could create these services was my wellness and is my wellness. And over the years, I titrated off my medication, found that I didn't need it, still use peer support, still use, that mutuality to support me, also do a lot of self-help for myself, developed my own wellness recovery action plan, which is called the RAP plan, to maintain my wellness. And so, and then people around me, if they see something that might be a little off, they'll let me know, and I'll get back on to my wellness to figure out what I need to do. As I've gotten older, it's gotten easier. And like I said, my passion is really my wellness.
Wonderful. And I love the idea of the wellness recovery action plan that, and, advanced mental health directives kinds of things, so that
Yes.
I'm taking a proactive approach to my whole mental and emotional health.
Exactly.
People like to talk about mental and emotional hygiene and how it's so important we do the physical hygiene on a regular basis, but we're not really conditioned or trained or even aware of the possibility. There's really good tools that I can use to clean up the inside on a regular basis.
Yeah, there's so much we can do for ourselves, and people don't know. So as our organization, our staff know, and they train others, and they help educate others in our communities on how to do that.
So if we have somebody who's listening to this who says, oh my gosh, I didn't know they had that kind of stuff, how do I start that in my community? Where do you point them?
So that led to something that I didn't expect, was consulting. And so we now consult. That's how we were able to help open 40 respites around the country and in Netherlands, as people heard about it. I started to go to conferences and do workshops. And when I first started, we were freshly new, and maybe 5 or 6 people would show up on my workshop. But as word has gotten out, the room gets pretty full now. And out of that, people call and say, we want to start this in our community. I just did a webinar yesterday, and I've gotten 3 people that have come forward and said, they're in different parts of the country and they want to start this. So for the most part, I will reach out and talk to people about what the possibilities are. I'll explore their system, because every system is different in every state and every county. I'll get to understand what their system looks like, and I'll give them tips and ideas on how they can start to develop a business plan on starting those services in their community. And then if they want to consult, we have a whole fee schedule that would help them to hire us to come out and literally help them design this and develop it.
Wonderful.
Yep.
So if you take a minute to just settle in and think about this range of things you've already shared with us, and if we ask you, what's something about either you personally, your journey, or the work you're doing that we haven't even touched on yet that you want to share with us?
I've gotten very big into understanding what integration and collaboration is, and in communities. And to me, asset-based community development became very important for me. And I think it's something that we still need to work on as a nation, in really building systems of care that work. Because if you look at the system now, we have law enforcement is becoming the first engagement for people with mental health or addiction issues. Why are we okay with that? We shouldn't be as a society. And I ask people that constantly. I'm even a CIT trainer, and a CIT is a crisis intervention team training that police officers get. It's a 40-hour training, and it teaches officers how to engage differently, because officers are taught to use command voices and control the situation. CIT brings it back to compassion and says, whoa, slow down to speed things up. You need these tools on engagement to talk to the person, listen to the person, find out a little more in depth what's going on with them, and then having the resources to understand as an officer, where can I send this person instead of arresting them or instead of the emergency room? Is there an option? And it's saving lives. It's helping officers do their job better. It's another tool for them. And I love the training, and I think it's vital for everyone to have, but we shouldn't just sit back and say, okay, we've got CIT now, they can engage and they can get people to where they should go. It really should be a system of care that should be the first engagement in working with people in our communities, and helping them avoid the criminal justice system. And we've become so criminal justice focused now. I mean, there, if you look at it in the country, there's criminal justice conferences everywhere all the time on engaging people and working with the behavioral health community on helping people through crisis. I think we've just really gotten too comfortable with that. And we should really think about, how do you develop a system of care that is pre-law enforcement, that is pre-criminal justice? And we should be able to do it. You know, we're pretty smart humans, and it's convincing people though to do it, because some police departments have completely embraced it. And they're like, we love it. We love having a social worker in the car with us. We love, okay, that's good. And right now, I think it is needed. I think it is important, because we don't have that system of care that I'm looking for. So my vision is developing an asset-based community that really focuses on understanding mental health, understanding addiction, so that our mobile teams can go out instead of a police department and engage people and get them to the services that they deserve and need before it gets to that level of crisis. So that's one piece of it. The other piece is that provider organizations do what they do, but they still live in silos. And people will say, no, we're community integrated, we do whatever. And I'm always asking for the proof of that. And I can always find limited proof. And I think we have a long way to go in really developing systems of care that are engaging, that are trauma informed, that, like we said earlier, people want to go to instead of being forced to go to something. And we can do it. And we're showing, with our services, that people want to come to us. They want to be part of us. And traditional organizations are now asking us, how do you do it? And so it's a whole engagement training that we'll give them on doing that. But I really believe that the community needs to step back a little bit and say, are we doing what's right for the people in our communities, and how can we do it better? And unfortunately, our paying system doesn't fall in line with that yet. And I think there's a lot of advocacy nationally that we need to be doing on getting the pay system to understand that there's a better way of doing this. There's a return on that investment if they do it. And we can create a community that is much safer for everybody, if we're all on the same page. And it's the challenge of getting everyone on the same page.
Well, I think that's one of the great benefits of what you're doing, and having it be evidence-based and collecting this data that you're able to show. Here's all this money that you don't have to spend if you put this money in this program. Right. Millions of dollars.
It's millions.
And it's so the people who want to focus on the dollars and cents, you're helping them. And those of us who want to focus on the humanity side and the compassionate care, they're seeing the results too.
Exactly. Yeah. So we've got work to do still. And I think that's what keeps me going, at least, in really trying to shift that paradigm to a wellness focus rather than an illness focus.
So the other question that pops into my head is, what kind of training do you give your peer support people?
Give them a lot. In New York State, there's a peer certification. So they go through the Academy of Peer Services, which we also, and I was also a big part of developing that, and what kind of training that is. And it's more of the mutuality training, the peer support training, the compassionate care training that is important. Motivational interviewing is part of it. Supervision of peers is part of it. So the certification is good. But then we also had to create our own training for the respite services because there wasn't any out there. So we created a whole ongoing training on how to work in the peer respites, which does include dialectical behavior therapy groups that staff get trained on. They get trained on applied suicide intervention strategies. So if somebody is suicidal, we don't dial 911. We go into the water with them and say, let's talk about this. Because when people will talk about suicidality, there's ambivalence. So there's reasons for living, reasons for dying. And as we have that discussion, that intervention, we get them more closer to the reasons for living through that discussion. And so, that's a big part of our training. And a lot of psych rehab is a big part of psychiatric rehabilitation is out of Boston University is a big part of what we do and how we train people in our services. Wellness recovery action plans, we train them on how to put those together, advanced directives, how to use those, and train people in our communities. But it's just ongoing training that we give our staff and make sure that any models of care that are working out there, they're going to be trained on it in our organization.
Excellent. I recently had the privilege of interviewing Paul Hendry, who works for the Jacobs. Do you know Paul Hendry?
Oh, yes. Yeah.
And the 1 Million Lives program that I thought of when you were talking about suicide, and their check-in at oml.world that's free to anybody, so they can do the ongoing status check of their own mental health, their feelings, their resources.
Right.
Wonderful. Well, is anything else you want to throw in here before we wrap this up?
I just I can't speak enough to the power of peer support. I can't speak enough to providing services that make sense, that are logical, by focusing on people's wellness and their strength. I didn't mention how strength-based we are. We work with some people that are in dire straits, homeless, food, have no food resources, have just living a rough life, and yet all of my staff are trained to look for the strength in someone, and that strength might be
they're still living, and
exactly.
They're living in some of the worst situations. A lot of us that we say, hey, this guy's so successful, this woman's so successful. Yeah, but they don't face what a homeless person faces. There's a lot of strengths there.
And we point out those strengths. And when we get calls from the county that tells, they say to us, we're working with somebody that we just can't work with anymore. We don't know what to do. We always take those folks on, because what I've learned is that people aren't trying to get over on a system. We hear that often, or they're manipulating the system, or they're just coming to the emergency room because they're hungry. Or what I tell them is, well, that's great though. That's a strength, because they learned how to survive, and you can use that skill that they have and direct it in a different direction for them so that they can live even a better quality of life for themselves. But we don't take the time to do that. In my agency, yes, we do. We take that time and we look at those strengths and we build on those strengths of the people we serve.
And then you build the resources that you can point them to. Exactly.
And we've seen thousands of success stories in this organization over the years. And it's something to be proud of. And we really want everyone to embrace not only what we do, but what works for the people in our communities, because we can fix this issue. We just have to have a concerted effort. And one of the things that I often say is that I always ask who's in charge. And if you think about it, there's never been a mental health czar in our country that has said, well, we're going to look at all of the evidence base, we're going to look at all the systems of care, and we're going to help design it so that there's fidelity in the services that people receive in our country. And I don't know why that hasn't happened, because it would make sense for me if somebody would take that task on and say, we're going to develop it so that when you do walk into a different state, you're not going to get different care. You're going to get care that is consistent with the way people should be treated. I understand the cultural differences, and that's got to be a part of it, but there's no reason why one county is one county or one state is one state in the way they care for the people in in their communities. So that would be another thing I'd want, the government to eventually look at and say, well, we need to do something about that.
Excellent idea. Well, I thank you so much for your time. I appreciate it. I know you got to run, but it's been a delight. And I will circle back in a year or so and see what's new in your life and see if you're
That'd be
willing to
great.
talk to us again.
I'd love to. Thank you so much for the opportunity.
Well, it's my pleasure, and you're most welcome and deserving.
Thank you.
Steve Miccio is Chief Executive Officer of People USA. Inspired and driven by his personal lived experience, Steve has spent over 2 decades creating, providing, and promoting innovative crisis response services and systems-level improvements, both across the United States and internationally. These improvements raise the bar on customer service, person-centered communication, trauma-informed care, empathy, and positive expectations for people's recovery and wellness outcomes. Steve's unique models and approaches significantly reduce hospital utilization, incarceration rates, and overall healthcare spending. Steve's professional highlights since joining People USA in 1999 include being the first in the United States to embed peers in a hospital psychiatric ER, blazing the way for a best of and evidence-based practice standard today. He created the Rose House model of peer-operated crisis respites, which are home-like alternatives to hospital psychiatric ER and inpatient units. He's the first peer-run hospital diversion houses in New York. He helped open 39 peer-operated crisis respites using the Rose House model across the United States and Europe. He has developed the OMH white paper, infusing recovery-based principles into mental health services, with input from over 40,000 New Yorkers. He created the Dutchess County Stabilization Center, which is the first peer-run crisis stabilization center in the world, and the first crisis stabilization center in the northeastern United States. He created the Transitional Care Wellness Team model, a unique hybrid of transitional care management and wellness coaching. He's developed unique training programs for hospitals, local government units, and behavioral health organizations across the United States to help them build tomorrow's behavioral health care workforce and culture. He organized and provided crisis intervention team trainings to hundreds of law enforcement throughout the New York area. Steve is active with a variety of groups, including the National Psychiatric Rehabilitation Association, and he's a board member of Psy.D International. He's a subject matter expert for Reentry Police Academy, headed by the SAMHSA Gaines Center and Policy Research Associates.
You've been listening to the On Your Mind podcast, offered by Journey's Dream, where we support people through mental health challenges to a place of true and lasting well-being. If you love our show, we invite you to visit onyourmindpodcast.org to join the conversation, access the show notes, and discover our helpful resources. Thank you for listening.